Good morning. I was somewhat surprised to see this session under the innovations in cardiovascular disease. Unfortunately, there hasn't been much innovation in the field of contrast nephropathy. Excuse me. So these are my conflicts. I got a fair amount of research funding, but mostly from government agencies, and I've been consultant to Osprey Medical. So why do we care about contrast nephropathy? Well, contrast nephropathy is common. Tom Tsai, who's in Denver, published this data from NCDR showing that about 7% of patients undergoing PCI in the country will develop acute kidney injury. Patients who develop acute kidney injury are more likely to die, more likely to have other complications such as bleeding and myocardial infarction, and they're also more likely to be expensive. So if you're looking at bundled care, patients with AKI will add about $7,000 to $13,000 extra to your PCI costs. So that is one reason why suddenly everybody's interested in AKI from whatever perspective you might sit. For a long time, there was a belief that AKI is sort of just a corollary to sick patients. So if you have someone who is sick, they get AKI, they also bleed, they also die. But there's some good basic data, actually data going back to the 40s. If you take a dog, and I hate dog experiments, but if you take a dog and you remove one of its kidneys and another half of the other kidney, so you're giving them non-dialyzed, like non-severe AKI, and then give them a burn, the healing of the burn is reduced. If you have a myocardial infarction in a rabbit and you have AKI, the healing of the myocardial infarction is impaired. So there are underlying biological underpinnings that impact why AKI might have deleterious effects among a patient that you're treating. Now, how do you prevent AKI? Since I have only 8 minutes, I thought we'll just go back to the guidelines and come to what do the guidelines say and why do they say that? So the guidelines give a class 1 indication, a class 1 recommendation that patients should be assessed for risk of contrast-induced kidney injury. Patients undergoing cardiac catheterization should get hydration. And then patients who are at high risk, and they define high risk as creatinine clearance less than 60, we should minimize contrast volume. Now, what is the biological underpinning of this hypothesis? Like, where does this come from? And if you think on a very simplistic terms, the risk of contrast nephropathy is directly related to how much contrast is in your tubules. So if you have less tubules, so a patient with chronic kidney disease has less tubules, and you inject the same 100 ml of contrast, so per tubule contrast that the tubule is seeing is much higher than somebody who has normal kidneys. If somebody has a low glomerular filtration rate, somebody is in shock, a patient that is dehydrated, they're less likely, they're going to have a lower GFR, so the amount of contrast that shows up in that GFR is going to be, and the glomerular filtrate is going to be higher. So one way to mitigate that is either you make sure the patient's hemodynamically stable, you also make sure the patient's well hydrated. And finally, the more contrast you inject, more contrast is going to show up in the kidneys. Beyond that, what causes contrast nephropathy is a fairly complex subject. If you had asked me 10 years ago, I could have given you the exact reason why contrast is toxic. The more I read about it, the more I understand that I don't really know. That means that there is a fair amount of confusion as to why it happens, but these underpinnings actually translate directly into how we can translate into better patient care. So how do you identify a high-risk patient? So chronic kidney disease, hemodynamic instability. There's one subgroup of patients, diabetes mellitus. So patients with diabetes, for the same degree of creatinine elevation or a GFR, appear to be at a higher risk for chronic kidney disease compared to patients who have other kind of chronic kidney diseases. So that is clearly something that is unique about diabetic patients. Then there are other rarer tubular disorders that seem to expose patients to more more contrast-induced kidney injury. The first case of contrast-induced kidney injury was in somebody with a myeloma. So we know myeloma proteins get deposited in the tubular region, and that's why these patients are more at risk for having contrast-induced kidney injury. There are multiple risk scores. The last count, this slide has not been updated. This was a review article by Judith Koeman from Leiden, and she listed, I think, 11, and after that, there have been about 4 more. So it seems like everybody produces a score. The problem with these scores is a lot of them predict your likelihood of having AKI after the procedure. Well, that doesn't really help you much because you can't use that to make any plan about your procedure or change your therapy or even inform the patient what the risk is. The score that I like to use is obviously the one that I developed. So this is based on a random forest approach. So what we do is we take, instead of one prediction, we develop 1,000 predictions. So for each, this is sort of what I call yesterday's AI. So we run 1,000 predictions. It'll give you the likelihood of AKI, need for dialysis, death, bleeding. So it's a multi-risk calculator. But with that, you get much higher discrimination than all the other risk scores. The problem with using risk scores is that the risk score, whatever you do, you can apply to everybody, right? Like minimizing contrast, making sure a patient's hydrated. So beyond consent, I'm still not sure why you should do risk score, except for a very high-risk patient. We'll come to that in a second. So how do you hydrate these patients? So there are a lot of hydration protocols. And what we've done in the state of Michigan under the BMC2 umbrella is try to come up with an algorithm that works for everyone. So we start with oral hydration by the patient. There are actually randomized trials that suggest oral hydration may be as good, small trials, but as good as IV hydration. So we start with oral hydration by the patient and then IV hydration in the cath lab. So what is a good oral hydration regimen? So we tell the patients, when you wake up, drink a glass of water every hour. So unless they have active heart failure, we tell the patient to drink a glass of water every hour until 2 hours before the procedure. Old patients don't like that, so instead of just saying you may drink water, we actually tell them you should drink water. That little change made a huge difference to the likelihood of patients showing up hydrated versus dehydrated. We've gotten rid of the NPO for cath order sets. So it turns out the anesthesiologists for moderate sedation have been saying that you don't really need to be NPO from midnight, which is what a common order set among at many hospitals for cath patients. So the idea is you should be able to give them free fluids, not milk, but free fluids, clear liquids, until 2 hours before the procedure. So then once these patients come to the cath lab, we take the Poseidon protocol, which was developed by Dr. Barar from LA. That is 3 mLs per kilo over an hour or 1 ml per kilo for 1 to 3 hours. The problem is, if you take Poseidon, that was a controlled trial, and there were a lot of patients that were excluded, patients with heart failure, severe valve disease, and so on. So what we've done is we basically made it simple. If you have active heart failure, you have severe valve disease, don't hydrate them. You can do a hemodynamic assessment, then decide if the patient is hydrated or not. Because a lot of the time, when you take a blind hydration protocol, you'll have one patient who gets pulmonary edema, and then you stop hydrating everybody. So it's better to be a little selective. So hydrate everybody except patients with severe valve disease or severe heart failure. And then in the lab, based on the EDP, you hydrate them from 1.5 to 5 ml per kilo for 4 hours. And that is a very effective hydration protocol. If you take this oral and IV hydration protocol, your AKI rates will come down a lot in your elected patients. Now, why does contrast volume matters? There's some controversy, and especially in the interventional radiology literature, you'll actually find people saying that there is no such thing as contrast-induced kidney injury, that contrast is very safe. So this is a rabbit model. This is from work from our lab. So this is grams of iodine per kilo. And to just give you an idea of what this relates to in a human terms, 5 grams of iodine per kilo would be roughly about 5 to 6 times your GFR. And in the state of Michigan, a few years ago, about 5 to 10% of the patients were getting that much contrast. So this is something that you will see in your clinical practice. So as the amount of contrast goes up, you're more likely to see acute kidney injury, shown in this slide by elevation in serum creatinine. Now, this is a renal cortex. So this was the first time I looked at renal histology in one of our studies. And I was actually impressed as an interventionalist, and I could tell that these kidneys don't look normal. Well, of course, I had a comparison of a normal kidney, but you can see the kidney on the left looks much more injured than the kidney on the right. So even among patients where we're giving our normal volume of contrast, you will see some contrast injury if you were to biopsy the kidney. The good thing is kidney has a lot of nephrons, so it's not a big deal. You can lose a few nephrons and nothing happens. Now, how do we translate that data into clinical practice? So this is work from our group again, showing that if you look at the amount of contrast a patient received and ratio that to the GFR, so the relation is nonlinear. So up to about a ratio of 2 times your GFR, your risk is very low. So there are the bar graphs are the risk of AKI, the line graph is the risk of going on dialysis. They're different scales. Then if you go from 3 times the GFR, to about 5 times the GFR, the risk goes up considerably. But then you go beyond 5 times GFR, and in this study, 10% of the patients actually got somewhere between 5 to 10 times the GFR. We excluded those who got 10 times GFR. There is, in our state, there's almost 1 or 2 patients who will end up getting about 1 liter of contrast in a case. That usually happens. Now, I know we're like, how the hell can someone be that stupid? It usually happens because you start, for example, that guideliner injection that you saw that led to left main dissection. So you start with something that looked very simple, turns into a mishap, and then one thing leads to another, and you're trying to bail out. Kidney is the last thing if you can get your patient's heart saved. So those cases are an exception. So another way to look at it is we looked at multiple subgroups. So what do you see? I think the most noticeable thing is if you're using less than 2 times GFR, in elective patients, no patient went on dialysis. This was a study of about 80,000 patients. So using GFR-based dosing of contrast, you can reduce your likelihood of acute kidney injury considerably. How do you reduce contrast volume? Well, first thing is, if you know going into the case what the patient's GFR is, that itself will make everyone aware of how much contrast you use, and that changes practice. Second thing is to have a feedback loop in your cath lab so that you track patients that got high contrast dose. In our lab, we actually write on the board what's the GFR and what's the threshold for 2 times and 3 times. And just when we started doing that, we saw a reduction in the total amount of contrast that patients started getting. The other thing which we do is we look at, in our EMR, the sky risk model is embedded. So anybody who's high risk, and we are extremely high risk, meaning more than 7% risk of AKI, we will use mandatory biplane, and we will try and minimize contrast using other tricks, like using more IVUS, you can put buddy wires in side branches so you can position your stent and so on. I still have not done a case with 0 contrast. I will do everything, but in the end, I have to take 1 picture, so I'll take like 6, 7 mLs. But there are people who've done cases with 0 mLs of contrast in very hard cases. And well, we do have, there is one innovation in this space, I guess, a new device called Divert, which diverts the excess contrast so you do not inject as much contrast into the aorta. So that acts to divert the contrast away from the patient into a compliance chamber, and that, at least in the early study, seems to reduce contrast by about 20 to 30%. So in conclusion, how do you prevent AKI? The first thing, hydrate your patients, minimize contrast volume, monitor your contrast volume, and use renal function-based contrast thresholds. Thank you.